Dear colleagues, small pupils were always being considered as one of the major challenges for the cataract surgeon. There are many different systemic and ocular comorbidities leading to insufficient mydriasis, starting from age-related diabetes, pseudoexfoliative syndrome, glaucoma, and many others. By dealing with such a patient, it's not only a problem of getting a good access to the lens and having a good visualization of lens capsule and cortical material. There is a risk of additional trauma that can be caused by vibrating ultrasonic needle or other instrument touching the iris and damaging the iris. The surgeon usually have a limited access to the lens, limited area for manipulations. It's quite easy to aspirate the iris and to damage it. It's not easy to access the equatorial portion of the capsular bag, to clean it completely from the cortical material. And there is a challenge for the surgeon to be sure that implanted IOL is located right inside the capsular bag in the correct place. It is especially true for patients where toric intraocular lens are being utilized, because it's not so easy to visualize the marks on the optics to be sure that the lens is in the proper position. In that particular patient, the pupil is not very small. However, we can see that the iris is incarcerated into the main incisions and into the side port incision, and this is the condition we know as an intraoperative floppy iris syndrome. Intraoperative floppy iris syndrome, described by David Chang and John Campbell in 2005. And we know that it consists of three characteristic symptoms: with the iris that billows in response to normal irrigating currents. There is a marked propensity for the iris to prolapse into the phaco and side port incision, and happened in that case. And there is a progressive pupillary constriction during the surgery, making it very difficult to remove the lens and implant the IOL in the capsular bag. Obviously, these cases need special attention and care. In the original article, the intraoperative floppy iris syndrome was linked to the patients who were taking alpha-1 antagonist medications, the patients having benign prostate hyperplasia. It was shown that these patients often have poorly dilating pupils preoperatively, and intraoperatively these pupils behave abnormally. There are several IFIS risk factors involved, such as gender, age, systemic hypertension, and intake of several types of medications. In the big case series analyzed by Tsamales and his colleagues, incidence of IFIS in men is 4 times higher than in women. However, there was no significant difference between sexes on posterior capsule ruptures. So IFIS raised the incidence of this complication in both sex groups. Here is the list of drugs that is correlated with intraoperative floppy iris syndrome, most of them having alpha inhibiting properties. And these are not only the drugs that are used for benign prostatic hyperplasia, but also for anxiety disorders and systemic hypertension. Pupil, which is smaller than 7 mm initially, is very specific factors that is predicting intraoperative floppy iris syndrome. And there is also significant relationship between short axial length and intraoperative floppy iris syndrome. This is a study published in Ophthalmology in 2014, showing that mean preoperative pupil diameter of smaller than 7.5 millimeters is correlated with almost fourfold increased risk of intraoperative floppy iris syndrome. Since pupil and cornea sizes are different among races and individuals, the dilated pupil to limbal diameter ratio was proposed as a more objective measurement for intraoperative floppy iris syndrome development. A ratio less than 0.6 was found positively correlated with the development of IFIS. Coming to the pathophysiology of IFIS syndrome, we can see that there is effect of alpha-1 adrenergic receptor antagonist on iris dilator smooth muscle anatomy. And in patients having tamsulosin, the thickness of that muscle is significantly lower. This also correlates with in vivo studies utilizing anterior segment OCT, measuring the thickness of sphincter muscle and dilatator muscle. Here you can see that the dilator to sphincter thickness ratio was much lower in patients treated with tamsulosin as opposed to the control subjects. IFIS incidence is quite variable. In the relatively big populations of patients, it was shown that the IFIS incidence is varying around 9 to 12% of all cases. IFIS is lower in Asian populations. However, its prevalence in patients taking tamsulosin ranges from 40 to 86%. How do we classify IFIS? From grade 0, when there is no signs of that symptom, to mild, when there is only iris billowing present, moderate, billowing and intraoperative meiosis are present, and severe, when the classical triad of symptoms present in these patients. It's very important to mention that the development of IFIS can be observed in patients only 2 days after tamsulosin intake, and making it unreasonable to cancel the medication before cataract surgery. Intraoperative floppy iris syndrome results in significant complications such as the partial or complete loss of iris tissue, leading not only to cosmetic but also functional defects. Other complications including increased ocular inflammation, posterior capsular rupture, anterior capsular tears, vitreous loss, iris trauma, and cystoid macular edema. Posterior capsular rupture can happen in 7 to 12% of cases. However, with adequate awareness and proper preventive measures, the rate of that complication can be reduced to almost zero. How do we prevent IFIS and how can we treat it? Here is the standard topical mydriatics protocol, which is including tropicamide, cyclopentolate, and phenylephrine. Disadvantages of topical mydriatics are well known. They including long induction time, poor bioavailability because of the low passage through the cornea, epithelial toxicity, and the possibility to absorb through the nasolacrimal outflow tract, leading to systemic side effects. Several studies presented evidences that adding atropine and non-steroidal anti-inflammatory drugs to preoperative medication protocol may be very helpful in preventing and controlling IFIS. Intracameral injection of phenylephrine is extremely effective in opening the pupil and increasing biomechanical rigidity of the iris tissue. However, in some cases, it is having a limited ability to expand the pupil, such as in that case, a patient having pseudoexfoliative syndrome and glaucoma. You see that the pupil starts to open, however, it stopped at some point and the pupil did not reach the desirable size. There are several intracameral mydriatics that can be utilized to open up the pupil, such as phenylephrine or epinephrine or combinations of these drugs with non-steroidal anti-inflammatory drugs and anesthetics. Intracameral mydriatics decreases the surgical time and the need of mechanical pupil dilatators. There are commercially available combinations of phenylephrine and non-steroidal anti-inflammatory drugs that can be added to the irrigation fluid, and the constant irrigation not only helps you to maintain the pupil in the open position, but also decrease the unwanted sensations of the patient during surgery. Coming to the surgical technique, in small pupils, it is recommended to use anteriorly elongated corneal incisions to position the entry point into the corneal wound further away from the iris root. Hydrodissect very gently to avoid iris prolapse. Lower the fluidic parameters of the phaco machine, and keeping the irrigation flow above the iris plane, which is more useful for bimanual rather than coaxial cataract surgical technique. Surgery in IFIS is longer than in the regular cases, and this is statistically significant. Proper use of viscoelastics may also help to stabilize the iris. Here is the soft shell bridge technique, which was proposed by Dr. Arshina, where the viscoadaptive viscoelastic is injected into the center of the anterior chamber and viscodispersive, filling the space above the iris and near the cornea. And there is a small slit of BSS filled space above the plane of the anterior capsule. Iris hooks are very popular devices that help the surgeon to stabilize the iris. It's usually recommended to use 4 of them to achieve square, well-dilated pupil. There is a specific type of technique utilizing iris hooks in a diamond configuration when one of the hooks is placed below the main cataract incision that helps the surgeon to avoid iris trauma when entering in and out with the phaco and irrigation aspiration probe. This is a very useful configuration when you consider using iris hooks. One of the options that can help you is to utilize APX or ACR pupil expander. This device can help you to reduce the number of incisions that are needed for expanding the pupil by the factor of 2 comparing to the iris hooks. My personal preference is to use the Malugin ring, which is the square pupil expansion device. This device concept is based on the paperclip principle, when the scroll of the device is used to catch the iris margin and hold it in expanded position. Having a specific holder and specific injector, it's quite easy to inject and remove the device from the eye. One of the major interesting features of that device is that it provides circular pupil in spite of the square shape factor of the pupil expansion ring. And this is because of the 8 iris retaining point principle. Here is the typical intraoperative floppy iris syndrome case when the pupil is quite big at the beginning of the surgery. However, as soon as viscoelastic left the anterior chamber, pupil starts billowing, prolapsing, the iris goes into the paracentesis, and this also complicates the surgery. The decision here is to insert the pupil expansion device, and again we see that after injecting elastic into the anterior chamber, the pupil expands, and it is now more or less in expanded state. However, we know that we need to stabilize that iris to complete this case successfully, which is now being done after implantation of the pupil expansion ring, and as you can see here, IOL goes into the capsular bag without any significant complication, and in spite of a little bit of depigmentation of the iris margin, the case was completed successfully. Why is the ring so helpful in stabilizing the iris and preventing iris buckling and billowing? This was nicely shown by David Lockington and co-authors, presenting the computer modeling of the intraoperative floppy iris syndrome depending on the size of the pupil. This is the not very well dilated pupil, and we can see that there is a billowing and buckling mechanism leading to prolapse of the iris. What's happening when we implant the Malugin ring? There is a little bit of billowing and buckling that happens in between the 8 points of fixation. However, this is not reaching the critical point when the iris starts to prolapse and the pupil does not become smaller. This modeling nicely showed that iris buckling can arise at lower pressures when the iris stiffness is reduced, which happens in floppy iris syndrome. And the pupil expansion ring inhibits iris movement by increasing the required critical pressures, kind of mechanical stiffening happening along with the pupil expansion. Currently, the surgical world is divided into two more or less equal parts. One is preferring iris hooks and the other one pupil expansion rings. Obviously, my personal preference is the pupil expansion ring, and why is that? It's shown on that nice picture. By utilizing iris hooks, we are having a square shape of the pupil, and we know that the perimeter of the square of the same diameter with the circle is longer than the perimeter of that circle, meaning that utilizing iris hooks, you always have a tendency to overextend the pupillary margin, leading to atonic pupils postoperatively. There are also many published evidences showing that in most cases pupil expansion rings are much easier to use. They require less operating time. They do not require extra incisions, provide stable pupil during the surgery, and minimizing postoperative pupil deformity. Here is the study directly comparing operating times, complications, and outcomes of small pupil cataract surgery in patients where iris hooks or Malugin ring was used. The result shows that the use of mechanical pupil expanders is an effective measure to prevent intraoperative meiosis and risk associated with small pupils. However, iris hooks cases took on average 10 minutes longer than Malugin rings in experienced hand and 18 minutes longer in younger surgeons. There are several other devices that are currently on the market, should be mentioned with respect to the pupil expansion as shown on that slide. Second generation of the Malugin ring is made of a thinner thread, and it is more elastic, more pliable device, which is very useful specifically in intraoperative floppy iris syndrome cases. The technique of insertion and removal is not very much different in between the first and second generation of the device. It can be both inserted and removed with the help of the insertion system as shown here, and it works very good for specifically intraoperative floppy iris syndrome cases. Here is the patient where femtosecond laser assisted technique of nucleus prefragmentation was used, and as a result of the intraoperative floppy iris syndrome, we can see that there is a progressive meiosis, and it was necessary to inject the pupil expansion ring not from the very beginning but in the middle of the surgery in order to evacuate the lens content more effectively. By doing that, you have to be quite careful not to catch the anterior capsular access margin with one of the screws of the device. However, with the proper precautions and technique, this case was completed successfully. My personal preference is to use the first generation of the Malugin ring in the very small and fibrotic pupils, such as patients having uveitis or glaucoma with posterior synechiae. And I do consider the second generation to be very useful in patients with intraoperative floppy iris syndrome. As a take-home messages, in small pupil cataract cases, I do recommend you to check patient history for medications, utilize preoperative atropine and non-steroidal anti-inflammatory drugs, inject intracameral mediatics, adjust the fluidics of your phaco machine, utilize viscoadaptive, viscodispersive OVD combination, and consider using pupil expansion rings or iris hooks. I do believe that with the latest advances in ocular pharmacology and new pupil expander designs, we should be quite happy with the options that we currently have for small pupil cataract surgery. And I thank you very much for your kind attention.